Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford. Today we are talking all about ovarian cysts, different types, how they can impact your fertility. You're going to hear some real life examples. Should you get them removed? What things I want you thinking about. I know that so often cyst is a 4-letter word, meaning you hear you have a cyst and it sounds automatically like it's the worst thing it could ever be. We have to remember that a cyst is simply a radiographic finding of a fluid-filled structure. And there's different type of cysts, some that are very normal and should be there, and some that are not normal and should not be there. And those that are not normal or pathologic have different implications if they are benign, or is there any concern it could be cancer. So it's normal anytime you hear the word cyst to have a minor freak out, but I will tell you, every day when I'm in office doing a series of ultrasounds, I will say the word cyst more than once, so it is not an uncommon finding. Before we jump in and really dive in, I just want to say thank you for all your support and love on the As a Woman podcast. We exist to talk about your body health, fertility, hormones, and really trying to help you live your best life and be your healthiest. You can ask questions. You will hear some of these questions answered in the episode. And you can ask questions at 657-229-3672. Again, that is 657-229-3672. You also can ask questions on Monday on Instagram at nataliecrawfordmd. Those questions will be answered right there on Monday. They will be answered at some of the end of the podcast episodes, and they'll be answered in the weekly newsletter. So if you have questions and you want to learn more about your fertility, the newsletter is super easy. You're going to get an easy fertility tidbit you can learn. We'll talk about fertility in the news. Unfortunately, there's been too much of it. We will talk about my favorite recipes, which I love sharing with you. Some of my very easy, family-friendly, hormone-friendly recipes. And then just some of my favorite things or upcoming events. And we've also started to incorporate some of your questions over on the YouTube channel. So Natalie Crawford MD is the channel name. You can search it. Over 200,000 subscribers and lots of short, easily digestible content. Easy to search, so if there's something you're looking for, jump over there. We're going to dive in and talk today about ovarian cysts, surgery for them, fertility, different type of cysts, and things I want you to know if you ever get diagnosed with a cyst.
Hi, Dr. Crawford. Thank you so much for all of your advice that you're providing on your podcast every week. I have a question. I'm 30 years old. I had a progesterone-containing IUD for the last 4 years that got removed 3 months ago. And my husband and I have been timing intercourse with my regular ovulation determined by LH strips, but we haven't gotten pregnant yet. I do have a 3-centimeter mature dermoid cyst on my right ovary that was incidentally found, and it's been stable over the last few years of monitoring. And my OBGYN said that that might affect fertility. And I was wondering what you would recommend. If it's not causing any pain, would you recommend removing the cyst and then continuing to try to conceive, or is it okay to just leave it? Just looking for a second opinion. Thank you.
Okay, so this is a good example of one type of cyst called a dermoid or a teratoma, but let's talk about ovarian cysts in general. So again, a cyst is a fluid-filled structure that you'll see on ultrasound. Now, about 6 to 7% of women will be diagnosed with a cyst, and especially a benign type of cyst. What we want to think about is the difference in functional and non-functional cysts to start out. Functional cyst essentially is a part of your normal function of your menstrual cycle. These are going to be follicular cyst or a follicle, which is growing an egg. This is considered a simple cyst, meaning on ultrasound, it is just a big black circle, mostly filled with fluid, gets bigger as the egg gets more mature. That will rupture when you ovulate. So you might have pain with that. if you ever have a cyst rupture, it's often just a follicular cyst, a follicle that ruptured with ovulation. That may be ruptured on an area where you had a blood vessel and could cause internal bleeding or be extra painful. But every month, if you're ovulating, you do have a cyst and it ruptures. It then reforms and becomes a cyst called a corpus luteum. A corpus luteum is a homogeneous cyst, so it's not as simple. It is now filled more with a fatty fluid substance. It looks gray on ultrasound. And this is your progesterone producing cyst that you have in the luteal phase. It is also functional because it makes hormones. Follicular cysts make estrogen, corpus luteum, they make estrogen and progesterone. So if I go and I do an ultrasound during your cycle, unless it's the very beginning when you're bleeding, your cycle day 2, 3, 4, 5, I will see a cyst most likely. And I will see either a follicular cyst as you're getting close to ovulation or a corpus luteum if you're in the luteal phase. These cysts come and go. They sometimes can stick around. So you might have a corpus luteum that hangs around and we might say, I see a cyst. It might be a corpus luteum. We'll keep an eye on it. That's because if I do an ultrasound another month, it will finally be all healed up and it won't be there anymore. Now, there are other types of cysts that are not coming and going, and these type of cysts will not go away unless you have surgery. And so type of cysts that we talk about here include an endometrioma, and an endometrioma is an endometriosis-filled cyst. It actually can look really similar to a corpus luteum, kind of gray and hazy, what we call homogeneous, but it is filled with endometriosis tissue. Now, this is a sign of advanced stage endometriosis. Remember that endometriosis impacts about 10% of women that we know about, and endometriomas are relatively common. Up to 40% of patients who have endometriosis will have an endometrioma. Simply the presence of endometriosis or endometriomas is harmful to your fertility. Seeing an endometrioma is one way we can get an ultrasound diagnosis of endometriosis. Remember, endometriosis is a surgical diagnosis only, but that endometrioma, having that inflammatory endo inside that ovary, is destructive to your ovarian tissue and to your egg count, and then also you have endo elsewhere causing inflammation in your body. Patients who have an endometrioma, even if they've not had surgery before, they have a lower ovarian reserve than people who don't have one. A dermoid or a teratoma is a more common type of cyst. About 70% of ovarian cysts are going to be dermoid. They can be on both sides or just one. They do grow, although typically they're pretty slow growing, and they can pose a risk. Any ovarian cyst can, but especially dermoids, of what we call ovarian torsion. Ovarian torsion is where your ovary twists on itself, and that can become a surgical emergency. Because a dermoid has multiple different tissue types in it, that's what it is. It's an embryological origin of multiple tissue types all inside a cyst. It can have fat, hair, teeth, scalp. It's crazy. And it's filled often with a lot of fatty fluid that can cause it to bounce or spin around. Dermoids have not been shown in the literature to be associated with infertility, meaning the presence of a dermoid alone doesn't cause otherwise body inflammation, it doesn't impact your ability to ovulate or have eggs, or appear to be destructive to your egg count in the same way that an endometrioma is. Meaning having an endometrioma, we know, is associated with infertility and associated with having a low egg count. What we do know is that surgery or removing a cyst has been consistently shown to impact your egg count or your ovarian reserve. And that is because when you take out a cyst, you are pulling that cyst wall and you are damaging other areas of the ovary. There are times where you have to have a cyst removed. These are times of ovarian torsion. So if the ovary is twisting on itself, losing its blood supply, you have no choice. That's an emergency surgery, and your options to lose the ovary or have them try to take off the cyst. As cysts get bigger, the risk of it becoming problematic, of it torsing or becoming an emergency increase. So if you're found to have an ovarian cyst and it's not functional and we're worried that it's endometrioma or it is a dermoid, for an endometrioma, you're going to hear me say, this is a sign that you have endometriosis. This can cause infertility and significantly changes our treatment plan. I do not recommend that we remove an endometrioma. Surgery to remove an endometrioma is associated with a drop in egg count, and it's not associated with an increase in pregnancy rates. So to me, the only reason to go to surgery is if you're having pain. If you have severe pain, if you're unsure if you have endometriosis, surgery can give you the diagnosis. But now we've diagnosed it, and if our goal is fertility, we're going to be best served by going on to IVF. That's because an endometrioma is advanced stage endometriosis. Now, if you've got a dermoid or a teratoma, this is not impacting your fertility, but surgery to remove it will decrease your egg count and does not appear to change live birth rates or treatment outcomes. However, if a dermoid is growing, if it is causing pain, if it's putting you at risk for ovarian torsion or limiting your activities, those are reasons to go and get it removed. Also, if it is rapidly growing or if there's any concern about what it could be. So a malignant or a cancerous tumor on the ovary is exceptionally rare in young women of reproductive age, but it's not impossible. They are what we call complex cysts, so they have solid and cystic components, and sometimes a dermoid has the same appearance. So a doctor telling you, I need to remove this because that's the only way I can know what it is for sure, is a valid statement, and that's a different scenario than us saying, here is a cyst, it looks like a dermoid, it is not changing or very slow growing. Those I completely recommend we just observe. If you have a cyst that is changing, growing, complex, we can't rule out that it's something bad, a different scenario. Of course, in those circumstances, you're going to want to ask your doctor, is there any way to just take out the cyst and not the whole ovary? That may or may not be possible depending on what the pathology comes back or what happens at surgery. And then you definitely want to have a game plan for the second ovary, meaning what if they find a cyst at surgery or something else happens? And this is often why if you're going to have a cyst and removed, depending on what it is or what may happen, you might want to consider egg freezing ahead of time. So to answer your question, I would not recommend that you go to surgery and get this taken out. I would recommend that you proceed with continuing trying to conceive and completing the fertility evaluation when the time is right. But unless you're having pain, I would not recommend excision of a dermoid.
Hi, Dr. Crawford. I've really enjoyed your podcast so far, and I wanted to ask a question. I am 26 years old. My husband is 32, and we've been married for almost 6 years. We always planned on starting a family around 5 or 6 years into marriage, and we were getting to about that point last year when I had an incidental finding of a large non-cancerous teratoma on my left ovary. I ended up having to undergo surgery and have my left ovary and fallopian tube removed, as well as the tumor. My right ovary had a benign cyst on it, which was also removed, but my right ovary and fallopian tube were left intact. Shortly after that, we decided it was best time to start trying, and I was cleared by my surgeon. We began trying, and I had a routine post-op ultrasound to assess my right ovary. Unfortunately, that came back abnormal, and another MRI showed that I have another teratoma growing on my right ovary. Right now it's small. The surgeon says there's no need to remove it unless it gets larger. She wants to monitor it every 3 months to see the size, and she said there's no reason that in the meantime we can't be trying. We have now been we've tried for 3 cycles with no pregnancy yet. Because of my history, I know I'm quite young, only 26, and only 3 cycles is not an incredibly long time to be trying. However, given my lack of second ovary, given only having 1 ovary and now having a second tumor on my only remaining ovary, I'm looking for some guidance as to what to do for fertility testing and trying. No one has really given us a whole lot of guidance other than just keep trying. But we want to make sure that we're still able to have babies before possibly, something could happen to my only remaining ovary. We do have an appointment with a fertility specialist coming up, but not sure what kinds of questions to ask or what kind of testing to request. Thank you so much for any guidance you might be able to give us.
Sending you so much love. I know that having surgery and losing an ovary is a big deal, and it must be just a lot of information coming at you that you've got a dermoid on the other side. So big, big hugs as you navigate this. To be honest, once somebody has had an ovary removed and you have only one remaining ovary, especially if you're young, especially if you want more than one child, this completely changes the game for me and changes my recommendations, because now I'm going to be highly protective of that ovary that you have remaining, because I know that you have a high chance of a cyst coming on that one. And in fact, you already have it now. So now our concern is, what if it grows bigger? What if you have ovarian torsion? You have to have emergency surgery. What if you lose that ovary? What if it can't be spared? Just have a cystectomy? Those questions cause me as a fertility doctor to have a lot of anxiety. And I'm sure as the patient, they cause that for you also. When I think about what I want to do next, I think, yay, I'm so glad you're seeing the fertility doctor. My strong recommendation is going to be that you freeze embryos. I know, but the reason why is that going through IVF, having a teratoma does not impact IVF outcomes, especially if it's small. As it gets larger, it might potentially block access to certain follicles. But getting the eggs out of your body, let's think about right now, you have 10 to 15 eggs available from one ovary any given month. You're just giving one a chance, and then the rest of them are dying, and then the next month having another group. And every month as that ovary is remodeling and healing, are we just waiting for this dermoid, this teratoma, to get bigger and become a problem? I don't know. You can use saved frozen embryos for a pregnancy even if you no longer have ovaries. So if something detrimental happened, you don't have to also wake up from surgery crying and mourning your fertility if we have embryos in the freezer. So my first step would be ovarian reserve testing. What's your follicle count? I would start by giving a strong consideration to embryo freezing or embryo banking. This means getting those 10 or 15 eggs available that month to all grow, taking them out of your body in an egg retrieval, fertilizing them with sperm, growing them out to a usable embryo, maybe doing genetic testing. I know you're young, but when you're doing embryo freezing specifically with the goal to use them later, knowing that you've got genetically normal ones completely changes the game. It improves success rates, and it allows us to know, quote unquote, when to stop. When do you have enough embryos to feel confident in the goal? So even though it costs more money, if you can, I think doing genetic testing is highly advantageous in this scenario. Our goal is to have 2 or 3 genetically normal embryos for every child you want. So unless your goal is I just want one kid, then it's a little bit different. But if there's even a small chance you might want to have more than one child, I recommend that we go through the process to save some embryos in the freezer. Depending on the other factors, you might say, oh, I've got 6 frozen embryos. I want 2 kids. Let's just do an embryo transfer now and get pregnant faster to get started on this track. Or you might say, I've got 6 embryos. I want to have 3 or 4 kids. I'm now going to save them and keep trying naturally, but I now have them if I'm having trouble or if something terrible happened to my only ovary. I'm not up a creek without a paddle. I've got options. And you can always use them in a few months if you're not getting pregnant. Let's say IVF is not an option or if it's off the table for you. Then at a minimum, let's make sure that all the other pieces of the puzzle are working. You only have one fallopian tube. Is it open? Hopefully there's no scar tissue or anything from surgery. How's the sperm count? What is your ovarian reserve? You are not like every other 20-something-year-old, meaning losing an ovary, having a cyst already on the one remaining one puts you in a completely different scenario. And I would approach it as such. I wouldn't say, compared to other people my age, or none of my friends have to do this, or I should have good fertility because something is different and I'm a planner. So I would, number one, get the data, do the testing. Number two, no matter the results, if there is a way to take embryos and put them in the freezer for later, especially if you want to have more than one child, that's going to be very, very helpful. I think your surgeon is doing the right thing. The recommendation is to monitor cysts every 3 months that are questionable, see how they're growing, see if they're changing, make sure there's nothing problematic. But what are you going to do if you go in 3 months and it has changed or something is different? What are you going to do at that timeline? Are you prepared to go to surgery? And what if the same situation happens? Or what if they take out the cyst and they leave your ovary, but what is little is not functional, barely has any follicles? It could dramatically change your IVF outcomes to do it after a surgery. I would not do that. I would strongly recommend you change your game plan and really consider IVF to freeze embryos now. I also think it's important to note that guidelines typically are conservative expectant management of a dermoid or suspected dermoid. If it's less than 6 centimeters in size, typically these grow less than 2 millimeters a year, and so they are typically slow growing. If it is rapidly growing or very large, then you're going to have to make a decision with your doctor on what is best, and that decision will be a lot easier if there are already embryos in the freezer. If embryos are off limits financially, you could put eggs in the freezer. One of the disadvantages of eggs is that we don't really know how many we need to achieve that saving or preserving our fertility, but anything that you could get in the freezer could really keep a door open for you that we don't know what will happen. If you do find yourself in the position of needing surgery again, definitely would talk to your doctor about a cystectomy, meaning taking out just the cyst and leaving the rest of the ovary if there is any way possible. But of course, I think it's really important to understand that things can happen at surgery that you don't have any control over, and that any doctor who would be taking you to surgery in this scenario would make you sign that you are aware you might walk out of there without your only ovary. So if you are in a position of having an ultrasound done and finding that you have an ovarian cyst, ask a few more questions. So what type of cyst does it look like? Okay. Is it a follicle, also known as a simple cyst? If you're in your follicular phase, that's probably what it is. Is it a homogeneous, or could it be a corpus luteum if you're in your luteal phase? Does it look like an endometrioma or a dermoid? Does it have more concerning features? Also, what is the size? Follicular cysts and corpus luteum are typically less than about 3 centimeters in size. They're typically a little bit smaller. If you have really large cysts, which is typically 5 or 6 centimeters or bigger, those are more concerning, and they do have a higher risk of ovarian torsion. So if that number is on the bigger end, or you don't know, say, is that big? Does this put me at risk for ovarian torsion? Do I need to modify my behavior? So ovarian torsion, my best example on how to prevent it is if you imagine your ovaries are water balloons, because they are at higher risks when there's more fluid filled inside the ovary. If you have a water balloon sitting inside your pelvis, I want that water balloon to stay in your pelvis. So anything that would move it up increases the chance it could twist on its blood vessels when it settles back down. So things like running, jumping, horseback riding, Peloton biking. If you are doing yoga and you do inversions, you do downward dog, anything where the orientation of your pelvis is changing could put you at risk. Now, things like walking, weight training, as long as you're mindful and in your brain, the question should be, can I keep these water balloons in my pelvis? Intercourse can sometimes be a risk depending on how vigorous we are. So I want you to think about keeping the water balloon still, and that might be hugely negatively impactful for your life. What if you want to train for a marathon? What if you are getting your yoga teacher certification, or you love that, and now I'm just telling you you can't do it? So you might want to get surgery as these things get bigger. It can cause pain. It can change or limit your activities, but it also can impact your fertility. So I don't want you to rush to surgery without understanding what could be going on, understanding the implications. And I would always, every fertility doctor will sit here and say, we'd rather do IVF or freeze eggs or freeze embryos before you get the cyst taken out, because we likely will be able to get more. We know your egg count's going to drop after you go and have surgery. If there's any doubt, if your doctor's saying you need surgery and you feel really confused, I'm not saying they're wrong, but you can always schedule an appointment with a fertility doctor and talk about, should you go through a cycle ahead of time, or get their takes, or get testing done, get the rest of your data, because understanding your body and having that data is going to help you make the appropriate next steps. All right, friends, we are going to answer some of your top fertility questions. These are questions that you have asked over on Instagram on Monday at nataliecrawfordmd. Remember that you can call and ask questions also on the voicemail like you heard in this episode. Those questions you will call 657-229-3672. Again, that is 657-229-3672. All right, how do I know if I'm ovulating? Well, there's a few different ways. So some of our body signs of ovulation can include the type 4 cervical mucus, which is sticky and egg white. You also know that you're ovulating if you have regular cyclic periods, meaning regular, predictable. I have my planner right here in front of me because I live by it. And if I open up next month, I could put my finger on when my period is going to start and be within a couple days of accuracy. I'm ovulating, my periods are regular, I'm not on any hormones. If you can't do that, that could be a sign of abnormal ovulation. But a very regular cycle is telling me that you are ovulating. Now, trying to determine when in the cycle you're ovulating, you can check cervical mucus, which is best to check wiping and looking at the toilet paper before you urinate, but when you go to the bathroom, especially around the mid-cycle. You can use OPKs, or ovulation predictor kits, which are a urinary LH-based kit. And I have a lot of content, especially over on YouTube at nataliecrawfordmd, about OPKs. But you'll want to get a urine sample between 10 a.m. to 2 p.m., starting a few days before you think you will ovulate. And the test will turn positive when your LH is surging, which ovulation will typically occur the next day. So if you get a positive LH, you're going to ovulate the next day. You can also do temperature tracking, which there are specific basal body temperature BBT thermometers. And this is confirming that you did in fact ovulate, less likely to be predictive unless you have very regular cycles and you really get in tune with it. But there's now wearables like the Apple Watch, the Oura Ring, that can integrate apps like Natural Cycles, which I am on their medical advisory board and I really do support the product, that can help you determine when you're ovulating. If the left tube is open and the right tube is proximally blocked, would you repeat an HSG? An HSG is a hysterosalpingogram. It is an X-ray dye test that we use to check the inside of the uterus and the fallopian tube anatomy. This would be a great recommendation for our second caller if she was not ready to do egg or embryo freezing, but wanted to see if her remaining tube is open. Now, in the perfect world, the dye goes all the way through the tube and you see it coming out the end. Distal or mid-tubal blockage, meaning the dye goes partway but not all the way out, that is always pathologic and real. Proximal tube, the proximal tube is the opening of the tube, occasionally can spasm. And in this case, you don't see any dye enter the tube at all. And you do not know if it's pathologic, meaning a problem, or is it just spasm because of the circumstance. If I have an open tube and then one that is proximally blocked, I don't usually recommend repeating the HSG unless I'm concerned that there is some weird tubal anatomy on ultrasound, because that's not really going to change my game plan. If the rest of the testing is normal and I have at least one open tube, I'm okay to proceed with lesser aggressive treatment options. It's not wrong, of course, if you want to get to the diagnosis, yes, doing a repeat HSG is going to help you get there, but that's not my favorite thing to do. It's not the most fun test. I only have egg white cervical mucus on one day, usually the day of or the next day from my LH peak. Is this my only fertile day? No, that's not your only fertile day, but it is your most fertile day. So we know that egg white cervical mucus is associated with peak estrogen levels. Some women have a couple days, some have one. This is also what triggers your body to send out that LH surge. So it should be close to when you're getting an LH surge in your urine. This would be the day I would absolutely target intercourse, but it's not the only day that you're fertile. The days before that, you likely are fertile too. But remember, once the egg has been released, it only has about 24 hours to get fertilized, and then the shop is closed. So if you are consistently getting that egg white cervical mucus, also known as type 4, if you stretch the toilet paper, put it in your fingers, you'll see it's stretchy. That would be a day I would definitely try to have sex. And if it's occurring on the same cycle day, say it's always cycle day 12 or 13, then remember sperm can live in the female reproductive tract up to 5 days. So I would target intercourse a little bit before then. And then whenever you see that cervical mucus, that is nature's lubrication. Hopefully that is a day that you can target intercourse and help you get pregnant. But you are fertile more than this day. You're fertile for about 5 days in your full cycle, ending on the day of ovulation. All right, friends. Well, hopefully you enjoyed some of these answers and learning a little bit more about your ovaries and ovarian cysts. Remember that you can call and leave a voicemail at 657-229-3672. You can also leave questions like these on Instagram at nataliecrawfordmd every Monday. And don't forget to check out the YouTube channel and the newsletter, nataliecrawfordmd.com/newsletter for more answers to your top fertility questions. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.